My name is Cristian Cobreros. I'm from Buenos Aires, Argentina. So my native tongue, of course, is not English. So you have to help me with that. I would like to thank you, Professor Carlos Ancona and Professor Castro Diaz, Beth Shelley that is here, Professor Beth Shelley that is here with us. I must say that Anand Patel is also in the house, so I'm kind of nervous of that. So thank you very much for this presentation and to be here. I'm very glad to be here all. So let's start with understanding urological clinical differences in neurodegenerative disease, and this my disclosure forms. I have no conflict of interest with these presentations. My aims of presentation are but neurogenic lower urinary tract dysfunction is one of the most challenging problems in urology, and the type of the dysfunction depends whether the level the intensity at the extent of the injury, and also the time length on a specific disorder as strokes, diabetes, multiple sclerosis, and so on. So we can find neurological clinical presentations that are not a static condition. So you may find a different clinical presentation even in the same disease at different times. So it's important to look up at the patient and closely behave by the clinical presentation of the patients, maybe different neurological possibilities. So for academic purpose, this is an schematic presentation of what it is: suprapontine lesions, spinal lesion, and spinal peripheric, all with expected symptoms and urodynamic findings. Although this specific type of presentation is for acute or for acute presentation of injury, we can take this for this matter as an example. So we're going to start with suprapontine lesions, and we are going to, in neurodegenerative disease, I put a stroke. Why? Because the stroke have not one but multiple strokes, and the strokes often the clinical presentation differs from 1 month to the other, and people get worsened with different ischemic or hemorrhagic strokes. So we do know that the stroke is very common, and it have 40% of mild disability of patients, of survivors, and 40% of have significant disability, and 10% require nursing home care. We do know that the disability adjusted life years for patients having a stroke is decreasing over the last 2 decades, but also people surviving a stroke with living with the disabilities or dying by the disabilities are increasing. And we know that there are different results in the disabilities adjusted life years in patients coming from the low-income countries that patients from for the first world. So this should take a lot of money to reverse, but something more cheaper and something more not economic issue would be something easy as control the blood pressure. It would be something less expensive, and you can do it. So in an acute urological presentation, urodetention may be the first urologic event to occur. So after cerebral vascular accident, and it's called the cerebral shock. The pathophysiology of this micturition is the disturbance involves two main aspects or two different mechanisms. One is there is often a decrease sensation and awareness of bladder filling, so which in another person, a common person, will lead to the sensation to urinate, but not in this patient. And the other thing is that there is a damage to the higher cortical centers, especially in the frontal lobe, which may as not easy to innervate the down centers of control of micturition. If you take the post-acute or chronic neurological presentation, of course, neurogenic detrusor overactivity is the main principal representation of the post-acute or chronic neurological presentation of the stroke. Urodynamic findings in reports, it takes up to 40% to 90%. And we do know that in this patient, urinary incontinence is the most common sequela, but as the point micturition center, who is the responsible for coordination of the sphincter, the relaxation, at the same time as the bladder contraction is unspoiled, this point micturition center, the ureteral resistance, the sphincter function, and the detrusor sphincter coordination may be well established. So maybe the patient is continence, but another symptoms are as present, and maybe the patient is not incontinence, but they will be present as nocturia, frequency, urgency, difficulty in voiding, and so on. So another problem in the supraventilation is regarding neurodegenerative disease is dementia, and we all know that Alzheimer's disease is most of all, the 50% of the dementia patients are in this group, in the Alzheimer's disease group. And urinary symptoms also present to 3 to 5 years after the dementia onset. We will not see as, for example, in multiple systemic atrophy, the multisystemic atrophy, the urinary symptoms are really appear in more early stages. This is uncommon in these etiologies that are presented in early stages. So the prevalence rate of urinary incontinence in dementia is really high. It's up to 53 to 90% in the trials. So, but we do have to make an exception of this and make a point out this one, because it's always misunderstood. Elderly population, which is obviously that people who have dementia is elderly, and there's always misunderstanding between elderly population who have a 5% of at least one urinary incontinence per week, and in dementia patients we have this percentage increase or climbs 5% to 75%. So it's not the same in elderly populations than in dementia in elderly population as well. This is a schematic pathophysiology of all the disease that we are getting to the cerebral cortex provoking dementia. And what is really important that we have two main effects. One is the neurogenic detrusor overactivity, and the other one is the gait disturbance, the cognitive decline, and the loss of initiative. So neurogenic detrusor overactivity we all understand, but when get to gait disturbance, we have another problem. And I have a professor that told me once the difference between us. I never forget it. The patients with gait disturbance seems to be difficult because motor disability to get to the toilet, and the toilet seems every day to be further away, and people with cognitive decline seems to forget where the bathroom is or where the toilet is, and people with loss of initiative seems to maybe they are in the bathroom, but they don't really care of where they are. So the problems get worse. That basal ganglia, the net effect of the basal ganglia over the micturition reflex is practically inhibitory. So when we do have the clinical response is a neurogenic detrusor overactivity, and you can get in Parkinsonian syndrome. We do have two principal clinical presentation, the gait disorders and the nocturia, which is an autonomic disorders related to the Parkinson. So Parkinson is a severe affecting quality of life measures, determine early institutionalization, and have a lot of health-related costs, and really is a common problem. This is a work of Pavlakis that mark what is, and at that time it was called the bradykinesia sphincter, now called hypertonicity of the pelvic floor. But it remarks when the gait reflex, the gait maturation reflex, is already present during the bladder filling, but at the start of the voiding phase, it didn't relax. So it's a differentiation that we have to make between this hypertonicity of the pelvic floor and the detrusor sphincter dyssynergia. They really make the differentiation over video dynamics. And this is one with this disease, the multiple system atrophy, often cause present with detrusor sphincter dyssynergia. How much? Maybe 30 to 40% of patients cause with detrusor sphincter dyssynergia, along with open bladder neck. See, open bladder neck at the start of the filling phase, so we can make a video dynamic and distinguish the two presentations of the Parkinson disease and the multiple systemic atrophy with a good video dynamic. Also, the presentation of the multisystemic atrophy is the incomplete bladder emptying as a significant feature in this disease. All the patients have more than 100 milliliters. Other autonomic manifestations are important as nocturnal polyuria or postural syncope in these patients. So you can see that also you have to take care of another kind of presentation, because multiple systemic atrophy present orthostatic symptoms, as we said, gait disturbance, but also erectile dysfunction. And for urologists, it's something that is a very common, consult to the patient to consult us for this, maybe for erectile dysfunction or urinary symptoms. So this, and the onset is really maybe years before the neurological presentation. So that give us is in the case that most of these patients seek urological advice early in the course of their disease, so we can put these patients into treatment or make a diagnosis. In multiple sclerosis, you know, this is the destruction of the myelin. This is a disease affecting multiple sides of the nervous system, and at the urological presentation, it affects bladder dysfunction. So the detrusor overactivity is mainly a presentation for urodynamics, and the symptoms appear by urinary frequency, urgency, nocturia, and urge incontinence. So by the presentation of this disease, we can say that urodynamic assessment is necessary for detecting neurogenic detrusor overactivity with bladder obstruction at the same time, which is so important to preserve the renal function. Urological manifestation can precede other manifestation for years, and clinical and urodynamic findings can change over time, so you must be careful and get involved in the clinical manifestation of your patients to detect any change as soon as it presents. Thank you.